When I consider second-line therapy for patients with advanced pancreatic cancer, a lot of it depends on what the treatment they received in the frontline setting was, and then again, always considering the clinical situation. What's the patient's performance status? What other medical problems have they developed? What toxicities have they experienced from their frontline setting? In general, when patients start with gemcitabine-based chemotherapy in the frontline setting, if they remain relatively fit and have not developed a lot of medical problems so that we are considering combination chemotherapy, I will generally treat those patients with nanoliposomal irinotecan. The data is really the strongest for that approach in the second-line setting. For patients who start out with the 5-FU-based chemotherapy approach, again, I'll switch to gemcitabine-based chemotherapy, and if they can tolerate combination chemotherapy, it'll be gemcitabine plus nab-paclitaxel. So that's the general approach. There are always considerations that you have to have if they've developed a lot of neuropathy in the frontline setting. I might be a little bit more reluctant to give a drug like nab-paclitaxel in the second-line setting. If they developed a lot of diarrhea or GI toxicities in the frontline setting, Nal-IRI may not be the right approach either, but for most patients, this is a sequence that I follow. For patients who are really fit and motivated, even in the community setting, I would encourage doctors to enroll patients or to encourage patients to seek enrollment into a clinical trial. For patients who are relatively fit and are motivated, in the second-line setting, I would still encourage community oncologists to either enroll those patients to clinical trials or to refer them to academic medical centers where they can participate in a clinical trial.
We see more and more patients whose pancreas cancer gets under control. We all were taught and learned that pancreas cancer is kind of a crash and burn disease. You help them a little bit, but not for very long. But now with our new medicines, we're actually stabilizing the cancer. There are more and more patients who are getting earlier diagnosis. There's improved recognition out there for diagnosing this disease. So you're having more and more patients who've been through frontline therapy, either benefited from that or stabilized on that, but then eventually progress somewhere 5-8 months later, who are still fine, right, and still doing okay, and want subsequent lines of therapy. So in that group of patients, this is a very easy choice to move on to second-line therapy. There are some patients who do not respond to first-line therapy, who right from the get-go are refractory to whatever treatment you propose. In those patients, we sometimes catch them, right? Their performance status is falling, they're not doing very well. We change therapy and we catch some of those patients. And so in my opinion, even in that patient population, if you've got the right pit crew behind them, good support, all of that, that's a patient that I also think should be exposed to second-line therapy in the hopes of getting that treatment to stabilize.